Hello, students. So something happened. We got disconnected. Let's going to start reviewing again the non-surgical management. I was playing a video, but let me go back to this concept. Non-surgical management. We are talking about a small bowel obstruction. Okay, so this is your chapter, concept of care for patients with non-inflammatory, and we are talking about intestinal obstruction. Okay, so let me go to non-surgical management. If the obstruction is partial and there is no evidence of strangulation or ischemia, non-surgical management may be the treatment of choice. Elimination patterns are expected to resume. Okay, so I was playing a video telling you how a group of doctors received a patient that was having a complicated case of vascular ischemia, and they couldn't figure out this problem, so the patient ended up with necrosis. Okay, so here you can see this is a patient weighing 88 pounds, BMI 13.8. He already lost a lot of weight. So you can see this is a diagram with the intestines, the colon, and this is the vascularity that I was telling you is in the posterior part of the abdominal wall, the mesentery. And this is another view of the same arteries. You have the superior, here is a lateral visualization of the artery. Now, the problem was an obstructed artery. The obstructed artery was having atherosclerotic obstruction, which could be diagnosed with imaging or by lab work, right? When you see the high levels of cholesterol, triglycerides, blah, 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 blah. So the vessel was occluded, causing the ischemia. And then that ischemia, you can see, caused the necrosis of the entire small intestine and the colon, and part of the colon. So this was a verdict of 1.67 million. Okay, and of course the doctors, they lost their license. Now let's talk about paralytic ileus, which is neuromuscular. Respond very well to non-surgical methods of relieving obstruction. Non-surgical approaches, and let's clarify, when it's paralytic, is neuromuscular imbalance, right? There is some neurovascular problem. So this is not, these type of surgeries sometimes, most of the time, I would say, when it's paralytic, responds very well to non-surgical methods. Non-surgical approaches are also preferred in the treatment of patients with terminal disease associated with bowel obstruction, right? Non-surgical approaches are also preferred in the treatment of patients with terminal disease. In addition to being NPO, of course, patients typically have a nasogastric tube inserted to decompress the bowel by draining fluid and air. The tube is attached to suction. Okay, so okay, nasogastric tubes. Let me talk first about this and then I play the video. So you know that there are different types of nasogastric tubes, but for this case, a Selam sump tube is inserted through the nose and placed into the stomach. It is attached to low continuous suction. Please go to your open lab, practice with this nasogastric tube, because are going to be very important for you to know the difference and how to use them. I found this video very helpful by Level Up RN. Let's watch this.
There are two categories of nasogastric tubes. The one I'm holding here is called a Salem sump tube, and it is used for gastric decompression. It is often inserted by a nurse at the bedside and is often used for patients that are pre or post-operative so that we can do that gastric decompression or lavage or temporary medication administration. So it's a thicker bore, meaning it's kind of wide. This end, of course, goes into the stomach, and the top end has a blue air vent and a second port, so it's double lumened. The second port is where I would hook it up to something like suction, and this is a temporary solution. If a patient needs longer term tube feeding, then they would not use this type of NG tube. They would use a much thinner, usually single lumen tube. Sometimes these are called Dobhoff tubes. It's just named after the physicians who created it. But because they don't need things like gastric decompression, you wouldn't need to use a tube that has the double lumen.
Thank you so much. Excellent. I will subscribe to the channel to follow up on more details. Okay, let's continue. That's why it's very important, nurses. It's very important to dedicate time. One more advice that I'm gonna give you. Don't be worried, concerned, don't be scared, don't feel ashamed. If you tell your supervisor or whoever is giving you the assignment in this hospital, you need to insert this tube, this and that, or give parental nutrition, this and that, or enteral, whatever. Don't be worried to say, you know what, this is my first time, or this is this task, I don't feel confident yet. Please show me. Please request help. Ask for help when you need, because the patient life is first. Okay, is first. Okay, please ask for help. Tell honestly, tell honestly, you know what, I need more training on this. That's better than have somebody passed away under your care. Okay, let's continue. Yes, Dr. Matalana, you are too much. You are scaring me. No, I'm just putting evidence up front. I'm just letting you know what could happen so you can prevent problems and complications. Okay? Nursing safety priority. At least every 4 hours, assess the patient with an NG tube for proper placement of the tube, tube patency and output, quality and quantity. And that's good to know. NCLEX alert. That's good to know. Okay, follow all these steps for proper nursing care. Monitor the nasal skin around the tube for irritation. This is very basic. I mean, it's really critical thinking, okay? Is logic. Use an approved device that secures the tube to the nose to prevent accidental removal. Assess for peristalsis by auscultating for bowel sounds with the suction discontinued. Thank you. Because I've seen, oh my God, I can hear these crazy bowel sounds. And the suction is in place. Now I'm laughing, but when I remember this, with the suction discontinued, suction mass peristaltic sounds. Okay. Suction mass peristaltic sounds. Now, if the NG tube is repositioned or replaced, confirmation of proper placement may be obtained by X-ray before use. Okay, so NCLEX question. I'm gonna tell you to pay attention to this NCLEX question. Also, if you have access to the 10th edition, also take a look to those NCLEX questions. Are very, very, very useful, helpful, interesting. Okay. The nurse is caring for a client recently admitted for a complete small bowel obstruction. What would the nurse priority action is for this client? The priority, incomplete small bowel obstruction. Are we going to prepare the client for abdominal surgery? Are we going to provide frequent mouth and nurse care? Did the stem of the question tell you that the patient was having NG tube? Assess bowel sounds every 2 hours? Well, I will do so. Dr. Madana, I will do so. But what is the priority? Monitor for fluid and electrolytes imbalances. We can assess bowel sounds after that, but fluid and electrolytes are the priority. And the rationale is There are a number of causes for complete bowel obstruction, and surgery may not be indicated to manage it. Therefore, choice A is not the correct response. The client would be very likely to have an NG tube inserted in need frequent mouth and nurse care as a result. The client, okay, would very likely have, but in the question, they don't mention it. Okay, so choice B is not the important action. Then the nurse would monitor bowel sounds to determine when they return, but this action does not need to be performed every 2 hours. Choice C. That's the protocol, the teaching of this book, right? In reality, okay, don't listen to me. Let's continue. The client who has a complete small bowel obstruction is a high risk for fluid and electrolyte imbalance from profuse vomiting. These imbalances may be life-threatening, therefore monitor for this complication is the nurse priority. Okay, please follow the book. Don't listen to Professor Matalana. Okay, please learn the basics, and then once you are in the field, you can see what the reality is. Other non-surgical interventions. Most types of non-mechanical obstruction respond to nasogastric decompression. Most type of non-surgical respond to nasogastric decompression. Obstruction, that's another one, caused by lower fecal impaction. So first we were talking about non-mechanical obstruction respond to nasogastric. Okay. Obstruction caused by lower fecal impaction usually resolve after disimpaction and enema administration. Okay. Intussusception, that's a third, okay, intervention. Intussusception may respond to hydrostatic pressure changes during a barium enema, meaning that the patient is going to receive barium enema with a certain amount of pressure, right? And that pressure is going to correct the telescope within the bowel, right? And it's going to be relieved by this hydrostatic pressure. For patients with a post-operative ileus, this is a 4 type, okay, almovipan, let me remind you, we had a patient who received anesthetic for this operative approach. Now, almovipan may be given for short-term use because we know the rationale. The anesthetic, the opioid medicine for pain in this type of surgery approaches can cause constipation. So that's why we want to give albumipan to reduce that constipation for surgery. This drug is an oral peripherally acting mu opioid receptor antagonist that increases GI mobility. There you go, increases GI mobility. So IV fluid replacement and maintenance are dedicated and indicated for a patient with intestinal obstruction because fluid and electrolyte imbalance is altered, particularly potassium and sodium as a result of vomiting. So any type of intestinal obstruction, mechanical or non-mechanical, fluid and electrolyte imbalance is our priority. We need to focus on that, okay? MPO status and nasogastric suction. Okay, let me repeat this sentence. IV fluid replacement and maintenance are indicated for all patients with intestinal obstruction because fluid and electrolyte is altered, particularly potassium and sodium as a result of vomiting, yes. MPO status and nasogastric suction, yes. Okay, so I didn't complete the sentence, that's why I gave you explanation without finishing the sentence. Okay. Care should be used for patients who are susceptible to fluid overload, older adults with a history of heart or chronic kidney failure diseases. Okay, so you need to identify your patient comorbidities and the whole presentation, and you need to be careful about providing care for patients with fluid overload, patients that are having congestive heart failure, okay, congestive heart failure, CHF, or patients having chronic kidney disease, because you're going to administer fluid and electrolytes, you're going to be given IV fluids, right? So you need to talk to the doctor, you receive doctor's orders, you question if the doctor didn't pay attention to this presentation, okay? Weight is the most reliable indicator of fluid balance, correct. Blood replacement may be indicated in strangulated obstruction because of blood loss into the bowel or peritoneal cavity. And that's good to know. NCLEX alert. Monitor vital signs and other measures of fluid status, urine output, skin turgor, mucous membrane. This is excellent. Good to know how you monitor your fluid status, urine output, skin turgor, mucous membranes. Parental nutrition, especially if the patient has had chronic nutritional problems and has BMPO for an extended period, you need to monitor that, and you need to ask the doctor to prescribe, to give you some interventions to do. The patient with intestinal obstruction is usually thirsty. Provide frequent mouth care to help maintain moist mucous membranes. A few ice chips may be allowed if the patient is not having surgery. Okay, abdominal distension can cause severe pain. The colicky crampy pain that comes and goes with mechanical obstruction, as well as nausea, vomiting, dry mucous membranes, and thirst, contribute to the patient's discomfort. Report any pain that significantly increases or changes from colicky and intermittent to constant discomfort. That's the situation is getting worse. So you need to identify the characteristic of pain. Okay, that's why the old car mnemonic is very helpful. It's gonna help you understand when this started, how is this relieving factor working on the pain, this and that. These changes can indicate perforation if the intestine is or in the intestines or peritonitis. That's why it's important to keep monitoring frequently, I would say, bowel sounds and pain. Analgesis may be temporarily withheld in the diagnostic workup period so that signs and symptoms of perforation or peritonitis are not masked. Wow, very important. Analgesics may be temporarily withheld in the diagnostic workup while the doctor is analyzing during the diagnostic period so that signs and symptoms of perforation or peritonitis are not masked. So patient may be asking for pain medication. You see the patient with a lot of discomfort, but the diagnostic workup is the imaging, whatever it is still going on. You need to trying to find ways. It's going to be very hard, but until the diagnostic is not finished, then you can go and prescribe pain medication. Follow instructions. I'm used to say prescribe because I prescribe medication. Anyway, morphine may slow intestinal motility, of course, and can cause vomiting. Vomiting are also signs of NG2 obstruction or worsening bowel obstruction. Vomiting needs to be analyzed. Why is this patient having vomiting? Why is this vomiting going on right now? What is the color? Okay, is the patient having fever? Blah blah blah. A semi-fowler position helps alleviate the pressure of the abdominal distension. Yes, on the chest. That's the most important. If we are having patient with fecal impaction, please put the patient in semi-fowlers. So we alleviate the pressure of abdominal distension on the chest and promotes thoracic excursion to facilitate breathing. Pain is generally less with non-mechanical less pain than with mechanical. With both types of obstruction, food or oral fluids aggravate the GI tract and increase pain. If strangulation is suspected, provider prescribe IV broad-spectrum antibiotics because bacterial overgrowth, right? In cases of partial obstruction or paralytic ileus, drugs that enhance gastric motility, prokinetics such as metoclopramide or Reglan may be used. Surgical management. Strangulated obstruction is if strangulated compression is complete, then they are going to do exploratory laparotomy, a surgical opening of the abdominal cavity to investigate the cause of the obstruction when it's performed. Okay, so when the patient has a complete bowel obstruction, the patient may feel too ill or understand the information, and in this case, reinforce the information with the family or other caregiver. Okay, during a conventional open surgical approach, the surgeon makes a large incision, enters the abdominal cavity, and explores the obstruction and the cause. If possible, exploratory laparotomy, right? If adhesions are found, there are cut and release. Obstruction caused by a tumor, this is another reason, right, of obstruction, or diverticulitis require a colon resection with primary anastomosis or a temporary or permanent colostomy. When intestinal infarction is the cause of obstruction, an embolectomy, thrombectomy, or resection of the gangrenous small or large bowel may be necessary. Most patients have laparoscopic surgery. This is another type of surgery, laparoscopic, for mechanical intestinal obstruction and do not have the NG tube. That's logic, right? If they are having a laparotomy, they don't need to block the intake of food because the patient is going to have a laparotomy, no NG tube. This procedure takes longer than the open approach, but blood loss is less and healing is faster. Okay, robotic assistant may be used. Now, for patients who have undergone an open surgical approach, an NG tube is put into place until peristalsis resumes. A clear liquid diet may be prescribed to encourage the return of peristalsis, and that's good to know. All this part in green is NCLEX alert. As liquids are initiated, the NG tube can be disconnected from suction and cap for 1 to 2 hours after consumption to determine whether the patient is able to tolerate them. If the patient vomits after liquids, the suction is resumed. Okay, and then the length of hospitalization for a patient having minimal invasive surgery to remove tumor adhesions or other obstructions may be as short as 1 to 2 days compared with 3 days or longer for patients undergoing a conventional open surgical approach. So now let's go to care, coordination, and transition management. All patients with intestinal obstruction are hospitalized, period. It doesn't matter if it's mechanical or non-mechanical. The length of stay varies according to the type of obstruction. Okay. Treatment and presence of complications. Okay. Patients who have complicated obstructions such as strangulation, that's good to know. What is a strangulation? The client who has a strangulated inguinal hernia, for example, would likely develop bowel necrosis, which can lead to sepsis. So when the obstruction is because there is an strangulation, okay, you can expect, if nothing is being done, that the patient is going to develop necrosis, sepsis, okay? Or incarceration. Incarceration is referred to as irreducible. It's used to describe a hernia in which their contents are unable to pass back through the hernial opening to the anatomical site of origin. Okay? Are at the greatest risk for incarceration. Patients with incarceration are at greatest risk for peritonitis, sepsis, and shock. So in both cases, you can end up with peritonitis, sepsis, and shock. Okay, home care management. Patients who have resolution or obstruction without surgical intervention are assessed for their knowledge or strategies to avoid obstruction recurrence. For example, if fecal infection in an older adult is the cause of the obstruction, assessment of the patient's ability to carry out a bowel regimen independently may be necessary. It's very important that you nurses have full command, full knowledge of the situation and the status of the patient, either the reason of the obstruction, how to prevent that, what are you going to teach to the family members, what age is the patient, if the patient understands the situation, if the patient understands and is able to return, right? When you say patient, return, demonstration, verbal education, okay? So all these factors need to be assessed in your patient during your patient education. Okay, so patient-centered care, older adult health, preventing fecal infection Everything in this table, everything is important. Teach the patient to eat high fiber foods. We spoke about that, especially plenty of raw. It does not say saute onions and bell pepper. No, it's raw. You want your onions? I will not suggest onion, but because it has a lot of gas content, I will suggest your peppers, your radishes, your all your greens, right? Um, what else you can get? Tomatoes, cucumbers, right? I wouldn't suggest broccoli, cauliflower, onions, garlic because they produce a lot of gases and they are very strong vegetables. You understand, right? So in this case, get your bell peppers, your radishes, your greens, tomato, cucumbers. What else? There's a lot of vegetables order. Okay. Um, I will get asparagus, right? um, Green beans. You can um, put them in a um, there's a blanching, I think it's called the process blanching. So you put a pot with water, a little bit of salt. You let the water boil. When after boiling, you insert the asparagus and the green beans for 1 to 2 minutes when the heat is off, because the water already boiled, right? So you just going to insert it for 2-3 minutes just to make it kind of a steam, right? And the colors of these vegetables are gonna become very green. It's kind of you are activating the good thing, the good benefits of the vegetables. Only for these two, okay? There is another one you can do the same, which is the Brussels sprouts, but Brussels sprouts belongs to the family of the broccoli and cauliflower. That's why I am not recommending that. Only asparagus and the green beans, and then when you eat it, it's going to feel the crunch still. Okay. Encourage the patient to drink adequate amount of fluids. In terms of raw fruits, let me go back. Raw fruits, try to select the fruits that are low in fructose. So your berries, your kiwis, your strawberries. Okay, those are the good ones. Do not get bananas, apples, mangoes, grapes. Those are high in fructose. Okay. Encourage the patient to drink adequate amount of fluids. Teach the patient to avoid routine uses of laxative, because the body gets used to the laxatives. Okay, but if you do your fluid intake, your high fiber, and your walking, you are good to go. You're gonna go every day, sometimes twice a day. Teach the patient to avoid routine use of a laxative. I read that. Encourage the patient to exercise regularly. We know that. The walking. The natural food to stimulate peristalsis, such a warm beverage and prune juice. Yeah, you can get warm, I didn't say hot. I said warm water with some drops of lime or lemon juice before meal. Okay, I have good experience with patients with hypertension and cholesterol. I suggest to get warm water, at least 2 liters of warm water per day, which is almost 10 or 16 glasses of warm water per day. Not hot, because if not, you're going to develop gastritis. But if you get warm water with some drops of lemon juice, you are going to start having a bowel movement. And after a month of continuous drinking these 2 liters of warm water with drops of lemon, you're going to see fatty in the stool. Fat in the urine, which is going to start cleaning your arteries and your veins. Okay, so it's double the purpose, right? The prune juice is for promoted bowel movement, but the warm water with drops of lemon juice is going to help you to also to have bowel movement and to urinate your fats. Okay, take bowel forming products to provide fiber and stool softeners to easy bowel elimination. Okay, most of the doctors are going to prescribe Metamucil, but Metamucil It's a product that contains several other ingredients, such as sweeteners, sugar or aspartame, and coloring. Instead, you can buy Psyllium husk, which is the natural form. It's a fiber, bulk forming natural. It's natural. Now, Psyllium husk, okay, you're going to find this in any pharmacy, even in Amazon, whatever. However, I'm gonna give you a hint, a very nice piece of information. Psyllium husk is also well known as isabgol, which is an Indian plant. So if you go to any Indian store and you buy isabgol in powder, you're buying Psyllium husk for half of the price. Get an Indian store close to your house, okay? And you will be able to have the same bulk forming product, okay? Natural, no sugar, no aspartame, for a very reduced price, okay? And it's not going to make you dependent like any other, like laxative, okay? So I will recommend that. Self-management in education. Instruct the patient to report any abdominal pain or distension, nausea, vomiting with or without constipation, because these symptoms might indicate recurring obstruction. However, the patient should be reassured that recurring paralytic ileus is not common. Recurrence in this is not common. Teach the patient who has had surgery about incision care, drug therapy, and activity limitations. Drug therapy may consist of oral opioid and non-opioid analgesics as needed for incisional discomfort. If opioid therapy is used, an over-the-counter laxative with a softener, Docusate with Senna, and let me remind you, Docusate is known also as Colace, which is a stool softener, may be added to prevent constipation and possible recurrent obstruction. Let me repeat that phrase because I interrupted to remind you the name of Docusate. If opioid therapy is used, an over-the-counter laxative with a softener, Docusate with Senna, may be added to prevent constipation and possible recurrent obstruction. Dear students, it was a pleasure to review this intestinal obstruction part of the chapter Concepts of Care for Patients with Non-Inflammatory Intestinal Conditions. When we come back, we are going to review the big one, colon cancer. Okay, it's going to be a big video, a long video, colorectal cancer. This is the terror in healthcare worldwide, the terror of healthcare worldwide. Okay, thank you so much for your attention. Stay tuned. We have more to share and more to learn.